record? No, we are recording. So welcome again. We will record these so they can be posted on the IHSC YouTube channel, and our previous editions have had over 100 views, so that's very good news. We are getting out into the world and sharing the information. A couple of things we want those of you who are attending the annual meeting in Atlanta to be sure to catch the roundtable that we're sponsoring. You can see on the screen. It's Monday, November 6th from 8:30 to 10, and it'll offer students a glimpse of career paths. Rachel, if you want to contribute, please do, and share what you have and what you know about the roundtable. So if you have any questions, you can email Julie. Her email's on the screen. It'll be available. But you can also email the APHA IHSC Student Committee Facebook. You can put a post there if you have any questions about that. So the other thing I'd like to ask is if you have any suggestions for speakers in the future. We have a few more months remaining for the year. If you'd like to hear anybody, or if there are topics that you'd like to see covered, please post it to the Facebook or email the careers email, which is apha.ihsc.careers@gmail. I know it's long. We'll figure that out. We do have room for 2 or 3 more. We are hoping to get a consultant next month, and then we'll have an APHA debrief. And then I am hoping to find somebody that'll focus on HIV, since December 1st is World AIDS Day. So that'll be nice. We would like this to be a very interactive webinar, so feel free to break in and ask questions of Debbie. If you're uncomfortable with that, you can push them in, type them into the chat function, and I will ask. And without further ado, one of my colleagues on the committee, Rachel Kennedy, knows Debbie. They're at Hopkins together, and she is going to introduce our speaker, and I'm really pleased to do that now. So Rachel, if you could take over, that would be great.
Hi everyone, I'm Rachel. I'm one of the co-chairs for the International Health Student Committee through the APHA. And I'm sorry if there's a little bit of background noise. I'm in a hotel lobby, so hopefully that's not going to be a problem. Just let me know if it is. But it is my pleasure and my honor to introduce my colleague and my friend, Debbie Wilson. She has graciously agreed to host this webinar for us about her plethora of experience working in nursing and health policy. A little bit of background on her: she's been a registered nurse working internationally for the last 30 years. She has specialized in trauma and worked in emergency medicine and neuroscience. She's also worked for MSF, or Doctors Without Borders, since 2004, doing emergency medical missions. She helped set up, amazingly, she's done everything from setting up a malnutrition project in Chad to a medical clinic in Haiti, as well as working with the Ebola crisis in Liberia, which launched her health policy career into motion, if it was not already headed that direction. But she has been a vocal advocate for speaking out about health policy decisions here in the U.S. And in the science community as a whole on recommendations for the public health officials regarding these very important issues. And so she has received many well-deserved awards for her clinical work, and as well as for her writing and research. And she's currently in the program with me here at Johns Hopkins, doing public health nursing and public health policy at Johns Hopkins. And she also, a plug for you, Deb, on doing your first triathlon. So incredibly in awe that you were able to do all of that at the same time. So without further ado, take it away, Deb.
Hey, thanks so much, Rachel. I guess first I just want to check that everyone can hear me. Somebody could type in yes, that would be great.
Yes, we can hear you. And thank you for being here. I don't know if I actually said that. Thank you so much for being here. Time out of your busy schedule.
No, thank you for inviting me. So as Rachel said, my name's Debbie, and tonight what I thought I would do, a lot of people graciously wrote in questions. So what I've done is base this presentation on the questions. So basically the questions that were asked of me surrounded some general topics. Basically, how did I get involved in global health? How do you move from being a clinician to working on policy? How do you take action in policy? And then there were some questions about the intersection between politics and public health, which is one of my passions or thorns. And there were also specific questions about Ebola itself. You know, how do we get ready for an epidemic? So I'm going to try and cover all of those. The way I work best is if people ask questions. So I have minimized the thing so I can't see the questions pop up. So Beth, I think I'm going to kind of need you to be my eyes. So I don't mind being stopped mid-flow if there's a question pertaining to something I've said, or otherwise we can just take questions at the end. So without further ado, as Rachel said, I've been a nurse for more than 30 years, and since it's mostly about international health, I got involved in national health largely starting because I was a young hippie and I always wanted to go to India. And I used to live in a tree house in New Zealand, and I kind of transferred to a cave in India. So, but while I was in India, I actually worked in Calcutta as a volunteer for Mother Teresa, and that opened my eyes in the home for the dying that she set up there, to what it was like to actually volunteer. And also it already started a lot of questions of how, as a Westerner in a country that's not your own culture, do you function effectively? And that's been something that's been on my mind ever since I started international health work, and continues to this day. So how more formally I got involved in international health is I applied and got accepted to work with Doctors Without Borders. And I'm going to focus largely on my most recent mission, which was going to Liberia during the Ebola outbreak. I did live in Chad for a year, working on malnutrition clinics, and then also lived in Haiti during the cholera outbreak, hiking up into the mountains to educate people about cholera with a team. So this picture that you see is how we crossed the border from Guinea into Liberia during the Ebola outbreak. And you can see that most of the stuff we shipped was supplies because they didn't have supplies. And what we're being rowed with there is a shovel, which is actually broken. So that's kind of life in the international world. And all my pictures of Chad and Haiti got destroyed, but this is how we educated about cholera. That's one of the pastors of one of the churches who became one of my best speakers about how you catch and transmit cholera. And all he was with his megaphone telling all the washerwomen in the river as we were hiking up into the mountains. And then when we would get to villages up in the mountains, we would find people non-responsive from severe dehydration from cholera. And so this is where putting in an IV and then transporting the patient in our Jeep down to a hospital. So this is where I treated 120 Ebola patients a day in 2014. I arrived there during the height of the epidemic, and it's actually, even though I've done international work, it was actually something that really changed my life. This is the team, and I just want to give a shout out to those West African nurses, especially these Liberian nurses. We only went for 6 weeks because of protocol. These guys worked the whole Ebola outbreak, and they worked most of it without being paid. So I want to give a shout out to them, and also I'm actually going back in November to interview them and hopefully get their story published, because I've been published after I came back, and I just feel that they've been forgotten, and also their perspective on how the health system should change so that an outbreak doesn't take off like it did before. Nobody's asking them. It's all experts that are Western and expats that are tending to to lead the conversation, and I feel I want to see more resilience placed within the countries. So that's really one of the ways that I've shifted from being a clinician to policy, is actually wanting nurses' voices heard more and wanting national staff, not international staff, stories told. If you do a lit search, you'll find tons of stories about expats, but not so much about national nurses. And just very briefly, we always had a buddy. We were double gloved. I'm an IV infusion therapist, and my job there was to teach everyone how to place IVs. If you can imagine in 110-degree heat being in this outfit, 120 patients lying on the floor, and they're all dehydrated from vomiting and GI symptoms very similar to cholera, trying to put in IV lines. And these nurses, we got an IV team trained, and they were phenomenal. And the improvement of survival was also phenomenal. And I actually read some stats that it went from a 30% survival rate to a 75% survival rate once we started aggressive supportive care, which meant IVs during the acute phase, antibiotics when needed. And we always treated malaria, but otherwise we couldn't treat anything else, which was also sometimes heartbreaking. This is a very different situation. This is the hospital. As you can see, a lot of it was outside. So when Ebola happened here in America, it was a very different situation. You're enclosed in hospitals. So of course, things had to be adapted. And as you can see, no computers, everything's handwritten. And that presented its own problems. But just to give you a sense, and I'm sure many of you know, so I don't want to go into a lot of detail. Probably a lot of you have done international work, so I'm happy to talk more about it if people want, but that was just to give you a sense. But one thing I did want to highlight was more than 10,000 people died in West Africa of Ebola during that Ebola outbreak. And here in America, not one single person contracted Ebola on American soil. Eric Duncan died, and one of the Sierra Leone doctors who resided in the United States died, but both of them contracted Ebola in West Africa. 2 nurses contracted Ebola here in the United States, and Craig Spencer in New York City, he contracted Ebola in Guinea. But if you remember, if you can just cast your mind back to the amount of panic and everything that occurred at that time, and just keep that in mind, as compared to here, where you see the burial teams were non-stop working. And one day I went out because so many of these people I had treated, and they hadn't made it. So it was quite something to actually go and just see the number of graves. And we couldn't send them home because they were Ebola patients. So this is a burial ground behind our Ebola hospital in the village that I was working. So just to give you some sense.
Debbie,
yes.
There's a question or a mention to ask about how humanitarian workers and public health practitioners treat and interact with local workers and patients. If you could work that into your discussion, I'm not sure if it's a convenient time now or if it's better saved toward later. So just if you could keep that in mind,
okay,
and if you don't remember, I'll try and do the same.
Sure, maybe we can do it later, only because this is actually my passion, exactly that question. And I do have some slides, I don't know if this would pertain, which in this, but I wasn't necessarily going to show them, of us actually working in a village where we're removing a dead body that's with Ebola and involving the family and involving the community. So maybe I could show those pictures, but yeah, if you could remind me later, because actually that would be something that I would really like to discuss. So when I came back to the USA, just to show you that sometimes it really is just timing that will switch what you're doing. I arrived on the 9th of October back here in the US. I flew into Newark, New Jersey, caught the subway into New York City, went to the Doctors Without Borders office to be debriefed, and went out for dinner in New York City. And as you see, I arrived the day after Eric Duncan died. 2 days later, or 3 days later, the first nurse contracted Ebola. So I've just come back from treating 120 patients a day. I'm on my 21-day self-monitoring, And I arrived back right at the time when America goes absolutely ballistic. Like Eric Duncan and all the mistakes that occurred in Texas, and then the first nurse was blamed. It was a breach of protocol. And then suddenly the second nurse contracted Ebola. And so then the hospital actually had to apologize to the nurses and actually rethink how they were doing it, how they were setting up their whole system of donning and doffing. They had refused to have the CDC come and help them because they thought they knew what they were doing, and of course then all the trust was lost in the CDC, and right at a time when we needed reliable speaking. Then, there was the whole thing, gosh, that's right, when she was on the plane, the healthcare worker coming back on the plane and everybody freaking out about that, and why was she called them and said she had a temperature and she was still allowed to fly. So, of course, even more mistrust. And then the famous statement that the congressman said, every outbreak novel or zombie movie that you see starts with somebody from the government sitting in front of a panel like this saying there's nothing to worry about. So that just set even more panic. And then on the 24th of October, Casey Hickox, I don't know if you remember, she was a nurse that came back from Sierra Leone, flew into the same airport as me and was placed in quarantine. Now, that was the final straw for me. If you think that I had got back and I was self-monitoring and going through all of this, having all my friends refusing to see me, my people in my apartment block tried to get me evicted from my apartment. Some kids threw stones at me when I was out for a walk one day. So it was actually for me more intense coming back. But this episode, when Governor Chris Christie placed Casey Hickox in quarantine in a tent when she was asymptomatic, and she even offered a blood sample and she was Ebola negative, and he still kept her locked up in there. And he said it was for protecting his constituents. That was the final straw. And at 3 o'clock in the morning, I wrote a letter to the New York Times. 9 o'clock in the morning, they called me and they said, we want to publish. And that was the shift for me from being a clinician to a policy worker. Because after that, I had to speak out. I had to speak out about politicians getting involved in making decisions without consulting public health experts, which is exactly what happened in New Jersey, and the damage that could do. Trying to enforce quarantine when all research shows that quarantine actually does not work. And now, as a result of the Ebola outbreak, WHO, it's now a policy of really trying to force people to not jump to quarantine, because whenever there's an outbreak, people panic, there's a natural fear, and people want to quarantine, and what happens is usually it's stigmatized populations that are quarantined. So people go underground, they try to run away, and if anything, that's going to spread the disease. So this slide just shows you that if you feel passionate about something and you start to speak up and speak out, if you've got a story to tell, you can end up getting published, writing, speaking, and that's actually what happened, which I was the last person that I ever thought this would happen to. So I think somebody asked, what action do you take? You do, if you care about something, do write. I don't know if people are all nurses on this, what other professions, but whatever profession you are, if if there's something you care about and you write from that context, you can actually make a difference. And I think that's important. And just to show my perspective on the Ebola outbreak, I thought that this was really important, that was published in the New England Journal of Medicine, that for those of us who lived in the early days of the US AIDS epidemic, the current national panic over Ebola brings back some very bad memories. The toxic mix of scientific ignorance and paranoia on display in the reaction to the return of healthcare workers from the front lines of the fight against Ebola in West Africa. The amplification of these reactions by politicians and the media, and the fear-driven suspicion and shunning of whole classes of people are all reminiscent of the response to the emergence of AIDS in the 1980s. So we'd already been through this, and yet here we were repeating the same thing. And I think that's something for us as public health professionals and those of us that want to get involved in policy and those of us that want to get involved in global health as well, because there will be other outbreaks for all the reasons that I'm sure you know that in countries such as West Africa, we're dealing with weak health systems. We're dealing with no running water. We're dealing with a lack of medical staff and supplies, no labs. I mean, for example, with Ebola, when the first cases happened in December, Ebola wasn't confirmed until March the next year in France and Germany. And that's because there were no labs in West Africa. Now, what if there'd been a lab right there? We might have known in December that we were dealing with Ebola and could have been responding much earlier. So for us as public health officials, there will be another outbreak of some kind. And how are we going to respond? And how, as we, those of us that are involved in international health and policy, are going to deal with this? And so I spent time really looking at what happens when there's that fear, and that fear starts to get out of control, and really that fear becomes more dangerous than the virus itself. And so what you end up with is a crisis in perception. So people are perceiving Ebola and thinking that we're going to run amok. I don't know if you can see this show, but how concerned, if at all, you are that there will be a large number of Ebola cases in your country in the next 12 months. And the US tops all countries in terms of the people that were very afraid. People watch the TV cycle all the time. As this, people trust information from acquaintances. And this was something that I really was also kind of shocking to me, given the amount of fear. All my co-workers who were, when I left, very proud of me for going. When I came back, they didn't know the difference between self-monitoring and quarantine. They actually didn't know how Ebola was transmitted, but they were working as nurses. And so, again, when something like this is happening, are we actually educated? And, because people will come to us. If they trust us, they'll come to us. So then we need to be communicating the correct information. So that meant that all my co-workers were actually feeding the fear because they were so afraid, which is also understandable because who was it that contracted Ebola in the United States? 2 nurses. It wasn't anybody else, but it was 2 nurses. We are on the front line. So helping to quell rumors and building trust. And unfortunately, with the mistakes that happened in Texas, that messed things up big time, I guess you could say. So I did research, and I came to Maryland. I was invited to come speak at Hopkins, and that's how I found out about Hopkins and got involved. But I met Dr. Sharfstein. We were at a conference speaking, and he at the time was the health commissioner of Maryland. And I was very impressed with what Maryland did and how what they did actually helped calm the fears. So these I don't know, I think you said this will go out, but I put these links up just so you can see how even in something as crazy as the fear and panic that gets out of control, there are things that you can do. Build trust in messengers. And this YouTube link just shows Sharfstein and speaking, and he's got all these doctors, which I have slight issue with because they never have nurses, because always the media wants the expert and it's always a doctor. But anyway, wearing white coats, standing behind him as they spoke. And the mayor started off by saying, look, the most important thing you can do is get a flu shot, etc. But it's a YouTube worth seeing to see how to actually try and calm fears, and not just use, because people don't use scientific information so much, but really trying to calm fears. The other thing, giving people something to do. They really started a surveillance and getting people involved. So when they felt they were doing something, that actually helps ease fear. And then the thing that I found from my personal experience when I came back is those of us that work in global health, or when you work in policy, touching people with personal stories really does work. I noticed that as I traveled around the country speaking at universities and things, as I told the story, people said, wow, I hadn't seen it like that, or I'd just been listening to the media and I didn't realize that actually this was true. Now my perception has changed. even, for example, of a lot of people that disagreed about Casey Hickox speaking up and things like that. So if you've got a story to tell, you need to be out there. If you've got a story to tell, get your story written, get to a policy table, because those stories do humanize something and decrease the fear and make people realize that they're dealing with fellow human beings. And the one interesting thing I found, because after is, people say, oh, you should be utterly transparent. And Maryland showed that that was actually increasing the fear. This picture is actually in a training, it's actually in Holland actually, but it's actually Westerners training for a potential Ebola outbreak in Holland. So they're practicing. But of course, once people became afraid of Ebola here, everybody that had symptoms of a fever, a malaise, which is the sign of flu, was isolated. And so reporters would keep calling the health commissioner of Maryland and everything, and they would say, well, now this person has been isolated until we confirm them if they've got Ebola or not. And what they realized, it was upticking the fear and the panic, because everybody was hearing about all these people that were getting isolated. And so then the rumor mill starts and everybody thinks, oh my God, there's 10 people with Ebola in Maryland now. So they actually stopped giving updates unless somebody was confirmed positive, and nobody was confirmed positive. Everybody came back negative with just the flu or a headache or anxiety or whatever. So that actually, then suddenly people aren't hearing those stories, so the rumor mill decreases and people start to calm down a little. And it actually really did have an effect in Baltimore. So I just wanted to communicate those, because it seems overwhelming in face of all the panic and fear, and people calling for travel bans, and Rwandan children being banned from going to school when there's actually more Ebola in America than there was in Rwanda, for example. So there really is a social justice issue here for us as public health practitioners. Now, somebody asked, did anything change here in America? And we did learn lessons, which I think are strong lessons for if there's another outbreak. The CDC provided new guidelines on training on donning and doffing PPE. They started having a trained observer watching you don and doff, and they learned that from us in America. And so that one, it's a shame that they didn't actually, again, it's like, oh, we're America, we're not going to get it. We don't need to do it like they do in Africa. But having complete skin coverage, having somebody talk you through don doffing so that you don't have to remember and think what order. They did start using a respirator here, which wasn't needed, but given the fear and panic, it was a measure that needed to be taken just to help calm people down. They formed an Ebola response team that could travel anywhere in the US for any confirmed case or suspected case. So these were highly trained people on Ebola that could arrive in an area and help guide the response, which was a good lesson learned from Texas. And the other important one, which is still in place, and I think will continue to be in place, they created a 3-tiered approach to hospital preparedness. So you had your frontline, all hospitals, because you never knew where somebody might show up with Ebola, were capable of isolating, but they would immediately transfer the patient to what was called an assessment hospital or a fully equipped Ebola treatment center, like what they have in Atlanta. And what that did was you didn't have to then train everybody in everything. You could actually focus on certain places that were highly specialized. And this was a huge help, because what happened was all the hospitals madly started stockpiling PPE. And so what happened, those of us in Africa, we had to start rationing the times we went in to see patients, because we didn't have enough PPE. And so in Geneva and places, they were madly trying to make more PPE to send out to us. But remember, I was trying to treat 120 Ebola patients. There were no patients here, but all the PPE was being stockpiled in the hospitals for the big what if. And then they upgraded guidance and monitoring of movement of travelers. And that did change. During my 21 days, I then had to start calling in every day. I had to graph my temperatures and everything. So it became more stringent, but it wasn't more restrictive. And so that was also actually good. Somebody asked to just very briefly about global health policy, lay translation of it. And I thought that was really good. There's so much policy that doesn't make sense. So I've put up three links or areas which I think are absolutely worth going. Time to Let Go, Remaking Humanitarian Action for the Modern Era by the Humanitarian Policy Group. It's a report that's very worth reading. And The Guardian, if you don't ever read The Guardian, they have a humanitarian page that is absolutely worth checking out. And again, because it's media, they sometimes the way that they report it's more understanding. And then just recently in June 2017, the Lancet put out a series about the humanitarian system and what needs to change to make the humanitarian and global health more appropriate to now, because it's still really a 1980s model. And then the final thing that I just wanted to respond to in terms of the intersection between politics and public health was that two things. One is, when Governor Chris Christie locked up Casey Hickox, there was an election going on and he wanted to look like he was protecting his constituents. Now, that could be sounding biased on my part, but the fact that public health professionals were not consulted at a time when there was so much fear in America, I feel is reprehensible. And what was interesting, I was speaking to the CDC person who actually was the liaison between the government and the CDC during the Ebola response. And he said that every single day he was inundated with phone calls from all the governors about, what was happening and what they should do, and people wanting to impose travel restrictions, et cetera, et cetera, et cetera. And he said the day after the November elections, all those phone calls stopped. Now, that was concerning to me because the Ebola outbreak had not stopped, but suddenly their interest in that Ebola outbreak had waned. And so how much rhetoric was it just to get the vote in the November elections? And that is concerning. And so therefore, those of us that are public health practitioners, again, that's why I think we need to transition between being clinicians and involved in policy, because we really do have a powerful base for a voice that I think actually can help in these situations. So really, that's all I have to say. And I work much better with questions, so please feel free to ask.
Okay, well, this is Beth, and if nobody else is ready with a question right now, I have two, going back to the point that we discussed before, which was the involvement of local health workers and how that influenced you, and what was your experience with that?
So I think something that it wasn't just during the Ebola outbreak, but every time I've gone out with Doctors Without Borders and working with the national staff, I've been very aware of the power dynamics and the inequality that you see. For example, I go to Chad or Liberia, and I'm always put in a supervisory position. And yet I don't know the culture, I don't know the language. And really, what am I bringing? Usually supplies that they need. Now, this is a broad generalization, but something that the reason I'm going back in November to speak with the nurses is that I noticed, particularly, probably because I was more experienced with international work, but there were a lot of issues when I arrived in Liberia. The Liberian nurses were fed up with a new nurse coming every 6 weeks. And so new protocols, and then they would be in trouble if they followed an old protocol from a previous nurse. And so they sorry, I've got these workers outside drilling. I hope it's not too disturbing. So, and I noticed that certain things would occur. Maybe I can give you a couple of examples. For example, when it was total chaos when Doctors Without Borders first arrived in the village where I was, which was the epicenter of the outbreak. There's been 50 Ebola outbreaks prior to this one. So, and Doctors Without Borders has been involved in a lot of them, but they have never had more than like 10, maybe 30 patients with Ebola before. And suddenly here we were having 120. So we were having to ratchet up systems that had only ever dealt with 30 people. One of them was trying to get clean water for everyone. And so they gave everyone could have bottled water. Now, once the water purification system was all set up, they insisted, and they stopped giving bottled water to the national nurses. The international nurses could still get bottled water, but the national nurses had to drink the running water. And they refused because they saw all the international nurses drinking water. Now, this seems like a petty thing, but for some reason it's the first one that I thought of. So then what they were doing was taking the bottled water that was going to patients. So they were going to be disciplined and even fired. So, but, you know, like when I spoke to the international nurses, they said, well, no, they're used to that water. And this is a very common thing. They are used to it. So therefore we can still have like more specialized stuff. So the solution was to actually have the nurses discuss with the water sanitation engineer. And in a discussion, the water sanitation engineer actually came up with a different system. So we were getting all the water from the river and purifying it with chlorine and flocculation. But she saw that she could actually get well water from the village and purify that and just have that for drinking, because the other water was being used for drinking, laundry, washing of patients. It was being used for everything, but it was just all, you know, purified. This resulted in a much cleaner water. It didn't have a yellow color. And then the nurses, the national nurses, were willing to drink that. Now, that came from collaboration and discussion, not just imposing a rule and saying, you're used to it, you drink it, we're still going to drink the bottled water. So it's these sorts of things, and I could give many other examples, that that need to be discussed more, and not. And of course, it is complicated, and why rules are put in place and everything. But this has become something that I feel passionate about. And the CDC has actually just given a huge fund to Hopkins to actually really work on how to improve the resilience of health systems within countries, so that rather than it being like the white savior, you know, that's all coming from the colonial past, swooping in and trying to help a country, you know, during an Ebola outbreak. It's like, how do we get those countries to improve their own health system and actually have the money to be able to do it, and give them the money so that they can do it rather than us telling them how to do it. So I don't know if that answers the question, or at least start the question.
It does, and it's much appreciated. Mary Beth has a question, and I'm not sure if you can see it, but Mary Beth, if you'd like to ask, feel free to open your mic. If not, I can ask on your behalf.
Mary Beth says, what aspects of health system infrastructures in Liberia and other West African countries could have the greatest benefit to containing Ebola outbreaks in the future? How could bilateral aid support these improvements? Well, I did research in that, and I think, for example, one thing is there's no labs in Africa, so they can't test for anything. So, and funding was given to start labs, and then of course the funding ran out, so it stopped, and so there's an empty lab, and then people started getting sick, and then it wasn't until blood was flown over to Europe. The increasing poverty there is causing people to go more and more into the forests to get food because they're starving. You go more into the forest, you're more likely to come in contact with animals like bats and contract zoonotic infections. So, and of course, so many nurses and doctors died. In Sierra Leone, 11 doctors died of Ebola during the Ebola outbreak. So starting to establish schools to train nurses, to train them to get bachelors and masters so that they actually have more education, because we always show that more education improves everything. So those are some things that we could invest money in. And then the other thing is actually something I just heard about today, and America is not doing it, but Europe is doing it, is actually giving cash to countries. Instead of giving the money to non-governmental organizations, and then them deciding what the country needs. It's actually giving the money to the country so the country can decide what it needs and how it's going to use the money to improve its own health system. And then simple things like sanitation, running water. I mean, here we have running water and chlorine. They just don't have that there. So again, giving these countries cash, they can start implementing, sanitation systems and such.
Debbie, can you see Barb's question?
No, I just see Barb saying yes.
Okay, so wait a minute, let me make sure I get everything in here. With the constant and continuous brain drain taking place in West Africa, how can the African division of CDC be developed to combat Ebola and other outbreaks?
It's not something I know so much about. In terms of the brain drain, I think you mean those that come over to America and train and then don't end up going back home. They might end up sending money back home, but they end up staying here, which is kind of understandable because the standard of living is much better here. But unfortunately, I don't know enough about that to answer, except I think, again, training people in their own country and, again, giving cash so that actually the standard of living can improve in those countries, then people won't necessarily want to come to America. Okay, so unfortunately, I'm not experienced in that to really answer.
a couple things that I'm aware of from past experiences, that NIH has a Fogarty AIDS International Training Research Program grant, so I don't know if they have a similar type of program that's focused on infectious disease in general or Ebola specifically, so that could be one mechanism. I know that at some point a number of years ago, a lot of that where the funds would be granted to U.S. Organizations, but at least with the program that I worked on, there was a sister institute developed in Nigeria so that the training would then occur in country. So that could be one mechanism.
Wow. Yeah.
The other question that I had was regarding labs. How does that coordination occur throughout the continent? Because I know that there are labs in Nigeria. I don't know what level they are, if they're BSL-2 or BSL-3, and what level lab is needed to work with Ebola, but I know that they exist. So how would the countries and the ministries of health or MSF, how would all of that get coordinated so that if a lab does exist that can provide the testing, that can get done without having to wait for months?
I don't know, because up until now it was dependent on funding. I forgot, I was going to say something and then something else came into my mind. The interesting experience that I had was when we first started, where we were treating 120 Ebola patients a day, we didn't have a lab. And so when we drew blood on the patients and we didn't know if they had Ebola or not, we had to put them in a container floating in chlorine, put it on the back of a motorbike, and it would go across the river and across the border to Guinea, where we did have a lab, to be tested. So it would take us 5 days to get results. So there were risk of cross-infection because we had people that we didn't know if they had Ebola or not, all in the same area, et cetera, et cetera. Then the European Lab Consortium flew over a team and a whole lab, and we set up a lab. I actually have a picture of it. And literally, once we had the lab, there it is, set up, here's the lab set up, we got results within 6 hours. And we dropped within 2 weeks, we dropped from 120 patients down to 60. And then it continued to drop because we were able to diagnose within 6 hours and start treatment. And so I don't know, again, do we give cash to the countries and they decide? Because, again, this lab could only test for Ebola. We couldn't test for anything else. So we couldn't test for electrolytes and things like this. So the argument is we should have been able to test for that so that we could do electrolyte replacement, et cetera, to help kidney failure and the such. So these are answers I wish I had, but I don't. Yeah.
No,
somehow I feel the answer is that we need to go back to the country itself, and rather than us deciding. But again, it's very simplistic, my reasoning.
All right, does anyone else have any questions or comments? Sometimes folks are curious about how to make the move from being a student to being a professional. I don't know okay, there we go. There's a comment from Barb, but Deb, if you could talk about that, what was your path? You've been in nursing for a long time. And how did you sort of break into public health? Was it, the hippie stage that you referred to? And
no, I think no. I think always, probably for all of us. Again, I don't know if people are nurses or not, but we're strong in advocacy. We want to really, nursing in some ways is a social justice. Is always dealing with social justice issues, and for the longest time, what I really cared about was making a difference to my patients, one patient at a time. And then two things, I think, with the Ebola outbreak, realizing that more needed to happen on a policy level to affect more people rather than just my one patient, suddenly became important to me. Now, was that because I have a lot of years of bedside experience and so I'm ready, and I'm older and so ready to move? Or was it just it was the Ebola outbreak, and also the opioid epidemic was another thing, because I had a lot of patients on chronic pain meds. And when the focus on the opioid epidemic was a criminal justice one and shutting down, so it made it very difficult for patients to get their meds, I saw a lot of my patients who were surviving at home, chronic pain patients or very ill patients on meds. They just started to buy the drugs off the street because they couldn't get to their doctors every 7 days to get another prescription, because they couldn't drive because they were on narcotics, or they were too sick and it was just too much. They had cancer or whatever. So that also, it was like, I could see how policies were affecting my patients. So then, rather than just trying to make it easier for my patient, it was like, I've got to deal with policy. And I can't say what it is that makes you want to shift to that, but just suddenly seems that's what needs to happen, for me anyway. I see a question from Melanie. I'm a nurse who works in public health at the country level right now for the past 7 years. My acute care experience is far out of date. I wouldn't worry, my dear, but I do have experience with some disaster response with Red Cross and Medical Reserve Corps. What else can I do to make myself a more attractive candidate to transition to global health? I think two things. The main thing is this, because you don't mention it here, is, or maybe you had a disaster response. If it's international, if you've worked internationally and proved that you can be in a situation where you don't have electricity or running water or whatever, and be comfortable with it, that's a big plus, because as Doctors Without Borders always says, what breaks down a mission is not, the intensity of the emission, the mission, the lack of electricity or the boring food or whatever. It's actually how the expats behave. And so if you have expats not getting on or really struggling with dealing with, not being able to have a shower or whatever, it can really mess up the mission. So that, and the other thing is being able to speak French, which I say slightly hypocritically because my French is really, really bad. But if you really want to transition to global health, the ability, because the Francophone countries are some of the ones that are really struggling more than the others. So often they need people in French-speaking countries. And then finally, because you're a public health nurse, don't sell yourself short, because that's actually where the strength is. And the most favorite missions that I had was when I wasn't actually at base working in the hospital, but actually going out and working in the communities. And so if you're strong in that, then you've got a gold ticket that international organizations need, because that's where the rubber hits the road, is working in the communities and with the communities. Yeah, time to brush up. If you saw how bad my French is, I still survived. Elementary level, if you're really bad, they can get a translator. And I was so lucky in Haiti because, of course, it's more Creole than French. And I had a translator. And actually, I'm still in touch with he was a young art student who looked like Michael Jackson. And it was just phenomenal to have a translator because there was actually a lot more that I could understand. And I learned a lot about the communities, about voodoo and how to work with the voodoo masters to actually help with the cholera and get them on board. So sometimes being bad, you get a translator and you actually are able to communicate much better. So don't let it hold you back. And of course, Gaza and places like that, you actually speak English. So you can also end up, a friend of mine who's fluent in French got sent to English-speaking missions, and me, who sucks at French, got sent to French-speaking missions. I mean, seriously. But anyway. So people looking for their first experience, again, if it's nurses, emergency medicine, but I think really you should speak up. If you're public health, really speak up to that. Again, I'm MSF. There's the Peace Corps. I don't know much about Peace Corps because I am an American citizen now, but I wasn't born here. And I think if you really want to do it, do it. Partners in Health doesn't take so many. There's smaller organizations, USAID, but that where you get more involved in policy. If you could even be a logistician, and if you want to find out more about logisticians, they are lifesavers for nurses, and a huge number of logisticians are needed for Doctors Without Borders. So if you don't have medical training, there is a lot you can do. And now they're also using cartographers. So, yeah, and social workers. So I don't know what career paths people are on, but
okay, with Debbie,
yeah, so,
we're coming up on an hour here. If nobody else has,
wow.
Look, there's a comment from Barb. She's returning Peace Corps volunteer. Welcome back.
Yes, welcome back. Right, and you don't do medical care, and yet you do a lot. And you're there for like a year to 3 years. So there we go. You don't have to be a medical person to make a difference.
So are there any other questions? Well, I'm not getting anything. So, Debbie, thanks so much for sharing your experience. We have recorded the entire, or almost the entire presentation. That'll be uploaded to the YouTube channel in a couple of days. Thanks so much for everybody to join us, and thanks so much to Debbie. It was an amazing discussion, and I learned a lot. I'm sure that everybody else did too.
Oh, well, look, thank you so much. And I did put up my email somewhere. So if people want to email me, people are free. Please feel free. And if you ever come to Baltimore, we'll take you out for coffee, Rachel and I. So.
All right. Thanks so much.
All right. Thanks.